hope I say it this time. Or you can add it. Yeah, in case.
Doesn't matter. It's very good. It's very natural, yeah.
You're right when we put in my.
Yeah, do you need to hydrate?
Right, you're right where I'm leaning my cameras, by the way.
Oh, yeah.
Yeah.
Sorry, I have to laugh. I had to stop myself laughing.
Doesn't need makeup.
Do you have foundation?
Foundation.
This man doesn't need it. He's natural.
A shot of whiskey would be nice.
Take a shot of whiskey.
Black
It's a
Jack Daniels or something.
All right, ready?
tell me if my
3, 2, 1, go.
Hello everyone, I'm Dr. Arthur Polela from Levin Wanawasa Hospital and an ambassador for the African Society of Regional Anesthesia. Today we're going to be looking at the erector spinae plain block, which is an excellent block for thoracic procedures, for breast procedures, as well as for your trauma patients who come in with rib fractures. So you need your screen to be directly opposite you. You need a linear probe in most cases for lean patients because the thickness of the erector spine isn't all that thick. For the slightly larger patients, you may need a curvilinear probe because you have more depth with that. For the needle, you need a longer needle depending on the habitus of your patient, but you should get away with 80 millimeter needle. So, assuming that all preliminaries have been done, that your local anesthetic dosages have been calculated, and that you've cleaned the area of interest, you now have to locate the landmark, basically. You look at the lower border of the scapula, palpate it like that. Once you have your lower border of the scapula, you go medially and place your probe about 4 centimeters away from the midline. So the ribs will appear as rounded structures, as you can see on the screen, the top surface of the ribs. As you go up and down, you'll notice that the ribs are arranged in the expected manner. You've got the option of counting from the lower rib to your desired rib of interest, but I like to use the landmark technique. And as you scan more medially, you'll notice that the rounded structure will gradually, first of all, disappear, then you have a flat structure appearing as you slide the probe towards the medial aspects. So let's have a look and see what we get. So again, you see the rounded structure. I will slide the probe more medially and wait for a more curved, more flat appearance. So there you have it. You have a flat transverse process. So that's the transverse process. And right above the transverse process, you have the erector spinae muscles. So your area of interest is the area just underneath the erector spinae muscle, hence the name of the block. So you've got the option of advancing your needle from the caudal end or from the cephalad end. I prefer to introduce my needle from the caudal end, and they say it causes the local to spread more cephalad in the more cephalad direction. So yeah, let's just make sure we optimize our image. There you go. You have your transverse processes right there. You introduce your, sorry about that. You introduce your needle about half a centimeter away from the probe at an angle of about 45 degrees, and it will come from the right side of your screen in this case, and you've got two options. Either the bony prominency, which is said to be a safe structure and therefore avoiding puncturing the pleura, but others have found that it's more you get more efficacy by having the soft tissue landmark, which is just the area right in between successive ribs. So once the needle comes in the lateral aspects, you aim for this area, and you see the local anesthetic spread upwards and downwards as well as a dark structure, and separating the erector spiny muscle from the transverse processes below. In this block, you will need about, this is a volume block, you will need at least 30 mils of your local anesthetic to have a good effect. And yeah, that should be your erector spiny block. Thank you very much.
We like it.
Say that again.
Then you want to do the adductor canal then?
Adductor canal.
That is your interspiny, he said. But
Erector
I
spiny.
think that can be mumbled up at the end.
Okay.
What did I say?
I don't know. It was
So
okay.
the erector spiny, you said interspiny.
Oh,
I think you can.
That's okay.
yeah, take it out.
Yeah. Let me just. My brain was saying erector spiny, but my mouth was saying something else.
Yeah.
Thank you.
What's next? Your
What's next?
No.
No.
Adductor canal, is it you or is it you? Okay.
You don't want to do it?
I think you must have better than me.
Okay.
If you want to do adductor canal, I think it needs to be Ryan.
yeah.
Huh?
You came to pull down your shorts, trousers, right?
Wow.
Oh,
Since you asked so nicely.
Dr. Canal.
I can do my adductor. Actually, I can do my. I can do my.
That's pretty.
Or shaved.
Yeah.
It's fine.
Alright, actually, Jean or Jan can do it better because you didn't have to uncover yourself.
Mind the screen, the
Mine
camera.
is very smooth.
Mind that camera when you get off. Just minding everything.
Just go that way. And just careful that way thing. You doing adductor canal now? Or is it? Okay.
Do you want to put your legs that far in so we don't need to move the camera too much?
Okay. Do you want to class sitting?
It's.
I just like that.
She can sit on the.
If you lie down, we don't need to move the camera so much.
Say it again.
If she lies down, we don't need to move the camera so much.
Left, right. Mine is very prominent. Thank you. There's a lot of
Don't you mind if I?
That's 2 marathons later. Thank you very much.
Okay, it's fine.
Which
That's
way
good.
do you want?
No, it's okay.
You want to speak to him?
No, because if I go the other side, we need to change this side. So we'll
then
just
we
skip it this
just
side.
keep it- So then do this then.
No, just
This
in
side.
like.
Yeah. Because then you're teaching students, but
Yeah.
we'll need the cameras.
Sit in that camera position, Ryan.
Yeah.
What position you want me? Semi.
Can I just scan, do a pre-scan?
In the meantime, we'll move the cameras.
So,
All the local camera to be.
You can just leave it there for now. Yeah.
You're probably
this is
going
the gas up
here-ish, right?
Say that again.
Where are you going to go?
So adductor canal, I'll go this way.
Okay.
Yeah. Because the femur comes this way.
It's really slow if you zoom out. And then
I've got pedicure on.
it moves a bit faster.
Yeah.
You really tell me where you are with the camera, Tom.
Say you want to zoom in where you are.
Yeah.
You're going to be flexing your knee or
Do
leaning.
you want me to semi-flex or
No,
what?
no, maybe
So you like that.
Okay.
maybe
yeah.
this.
Stay like that the whole time.
Okay.
Okay. So zoom out a bit. Then down a little bit.
Up a little.
Where can you put your probe on where you're going to?
I need to look for it at the moment.
Yeah.
So
You're made a fraction for today, so you can do anything you want.
Can you see my fingers, John?
Yeah, I can.
Yeah. Is that good for all cameras?
Your hands are warm for a
It's good
surgeon.
for that. It's good for that.
Where's your medical student?
The medical student needs to be here, right? So
Medical student is good, but just a bit closer though, closer.
closer.
Try and get it closer, really, John.
Right, okay.
Can we get here? Is that all right?
Right up against the edge of the bed.
Okay, that's fine, that's fine, that's fine, that's fine. And then if you pick up your camera, Sohan,
Yeah. I presume we're best coming this side.
the way that the probe, the way you'll be looking at.
Exactly this
Yeah.
side. Yeah.
I'm loving this gas.
You're not going to get anything with your elbow.
Where do you want this one?
Do you need my hand away?
No, I'm alright.
Just hold on for
Have I got enough?
We haven't got the screen.
This
The
one.
G screen.
Oh yeah.
So,
Where's your Sanskrit screen?
The
so
PT.
that needs to be for the PTZ.
Okay, yeah.
So direct it up a little bit towards G.
Okay, there we have it.
You're going to zoom out.
Okay, it's there.
I've got a weird angle. What's happened to my angle?
Up now, up,
Ah, yeah.
up, up,
It's just
up.
moved.
Zoom in.
My anatomy is weird.
Up,
Sorry.
up,
As in my anatomy in my head, like I haven't.
left.
Yeah, I hope I say the.
No, the other way.
You want to see jeans?
Do you want to try?
No, as in I've seen everything.
Oh, you've seen everything?
I've seen the landmark,
I'm going to lean on your shoulder, G.
Yeah.
That's
And
all right.
then
but I'm
the
thinking
anatomy.
there's the muscles. There's a sartorius, then there's a vastus, then
I've
there's
got anso. Do you want anso?
this muscle is what?
Yeah, and then if we use the PTZ to then zoom in,
Adductor.
it'll be fine.
It's adductor. It's a hamstring muscle. Adductor.
Longus, no?
I'll just say
There's
hamstring
adductor
muscles.
longus, adductor brevis, and then vastus medialis, no?
More.
No, vastus, one of the vastus.
Medialis, vastus medialis.
Vastus
Is it?
medialis.
Okay.
Who has an anatomy textbook?
He is an anatomy expert.
Okay, can you zoom in?
Huh?
It's crazy. You just need anso.
Let me see.
I was going to stand right over her shoulder and
Zoom down in.
do
Oh, your mum.
like this.
This is a really
I've got your, don't do that.
No?
That's covering the ultrasound screen.
Is it? Okay.
Right here.
Right, okay.
Careful the leads.
Yeah, no,
Do you want my
Do you
hand?
Don't
want
move
me?
back.
Uh-huh.
Alright, we need to zoom in slightly on the ultrasound if we can. It's a bit
Oh, oh.
far away.
There you go.
Careful your back.
Yeah.
Jag, is that zooming?
So any more?
Yeah.
That's max.
Yeah, like that.
Give us a disc.
Can you go closer to the table?
Yeah.
No, not you.
Oh.
Okay.
That's it, that's it. And then go down with the PTZ. That's it. That's better, yeah. So then you're in the camera shot.
How about now?
Yeah, so go around the other side of the 360 if you can, if
Say
it's
it again.
easy to let
Yes,
you,
you've got more than half.
and then go from there.
Okay.
But careful because you're pulling on one.
Yeah, no. Jean, do you mind if I just ask you to step back again for me? Just over the lead, step back once more. I'm just going to put the leads through this way, so that way I've got some slack. Lovely, thank you.
You
Okay.
need to position me again.
Yeah, so
It's like, I don't know where to go.
slightly this way. So Jag, take and then go this. That's it. Perfect. Yeah, that's fine.
Am I in the way of this camera now?
No.
No? Okay.
You guys want to shop in like this?
I might move this camera to here, John. Move this one to the end.
That's
Give
not
Sam a little bit more
Yeah, sure. That's what that'll be better anyway.
like that.
And
It's filming.
Yeah.
So I have my foot
Okay.
on.
My foot?
your angle is slightly wrong. You need. That's it. That's fine. Yeah.
Okay.
That's fine. That's fine. That's fine. Someone's got a good angle now.
Thank you.
Okay, we're good. I'm happy.
Medical
Don't-
students, that one, remember?
So-
Not Jean anymore.
Okay. Let me just give me a moment.
We don't film tomorrow this week.
3, 2.
Wait.
Sorry.
Needs a script.
He needs to run his script in his head. He's in another world.
What's the time?
That would be 6 something. 22 past 6.
Probably do another 2 or 3 then.
Yeah.
Okay.
We've got another 4 left, you said, right?
Ready?
Yeah.
Okay.
Yeah. So, Soham, get your camera ready.
Yeah, ready.
3, 2, 1, go.
Hello everyone, I'm Dr. Arthur Polela, anesthesiologist from Levi Mwanawasa Hospital in Lusaka, also an ambassador for the African Society of Regional Anesthesia. So today we're going to be looking at the adductor canal block, which is also called Hunter's canal block. It's a perfect block for knee surgery, for analgesia, and sometimes for your difficult patient for anesthesia as well when supplemented with a popliteal block. So the way I approach it, I go in the middle region of the thigh and scans from the midpoint going towards the medial aspects, looking for the femoral artery, which comes from the lateral aspects and crosses the thigh into, crosses medially going towards the popliteal fossa. So we'll put our scan more closer to the middle aspects of the thigh. It's a good block, especially that it is usually motor sparing for knee surgery. So yes, we put a probe in the middle aspect. You want your screen to be directly opposite you, and we're assuming that all preliminaries have been done, that your local anesthetic has been prepared in advance, and the area is sterilized as standard. So we're looking for a pulsating artery in the medial aspects of the thighs. So we'll move from lateral to medial, looking for the, let's see, looking for okay. So there we have it. We've got the artery right here, and above it is the sartorius, and posterior aspects you have the hamstring muscles, and in the anterior compartment of the thigh here. So you're trying to deposit a good volume of local anesthetic, depending on your indication, around the artery, and you see at the bottom of the artery, and you see the artery raise upwards. So you're going to approach your artery from the anterior aspects with the needle length, depending on the habitus of the patient. You usually get away with about an 80 millimeter needle, and you introduce your needle anteriorly in this manner. Let's see if we can demonstrate that. So aiming for the midline, you introduce it at about an angle of 45 degrees. Your needle will come from the right side of the screen and aim for the bottom corner here, and your artery will be pushed upwards as you infiltrate with local anesthetic. This is also a volume block, so aim for about at least 20 to 30 mils of your local anesthetic should give you good coverage for your knee. Thank you very much. Whew.
Just smiling or moving a muscle.
Let me just see if I can see something this side.
Oh, are you popliteal as well?
No.
We're just looking for my popliteal. Have I got anatomy?
Wow, there's an easy way to tell.
Yeah,
She's got a popliteal artery.
That's the dorsalis pedis, my
Exactly.
darling.
It goes from one artery, doesn't it? If you've got a dorsalis pedis, you've got a popliteal.
Wonderful.
Yeah,
If you didn't have a dorsalis pedis, then yeah.
right. Oh, sorry.
This one is one of those challenging ones.
Wait a minute, I don't always know how to put my needle for my popliteal. I tell you that for
It
sure.
has to be above the tendon.
Yes.
Yeah, so you don't go through it.
Do you need more depth? You don't need to be shy of saying that.
Somewhere at the top.
So it's small
Oh,
artery.
here we go.
The vessel is there,
Cool, cool.
and I think the nerve
That
is
blob upside,
There was
above.
something bright there.
Something
there,
bright.
this
Somewhere
here,
there.
Huh?
this white structure.
So we've got fasciolaca,
Oh, yeah,
Ryan.
Yeah. That's
and
one.
then we have also got tap block. We've got rectus sheath, and then we've got the popliteal. So there's 4 plus minus
Why
that.
don't we just do the popliteal if the legs are already out?
All right.
Oh,
Very good.
Can we switch the mic?
You'll be live after.
I'm going to have a row in Hollywood soon.
You have to go on your back, I presume. Or no? So you got to.
Just bend your knee.
It depends.
Okay.
What do you want? Yeah, what you want.
So I'll prefer on the side. Yeah.
Lateral, so that way.
Lateral. No, the other way.
The other way.
So I'm doing on that leg, and then this one is bent.
Which way you go?
Time again?
The right,
Yeah, you want to do my right leg?
but you need to be facing me.
Okay.
I'm keeping.
Yeah.
Can I have a bit of
Jean, you want to go?
white? That's okay.
No,
No,
actually.
he's going to scan my right leg.
I'll stand this
on
way,
the
yeah, so
screen.
you can still stand
Yeah,
that way.
fine.
So you're gonna
Danke
reach
schön.
over.
Oh, some use ways is fine. It's just for wiping the thingy.
She's going to reach down like this.
No, it's fine. We save some.
Why is that?
It's fine.
Why don't you go under?
No, because the patient's legs were short.
But why would you go over rather than go?
So I'm going to just be careful with this thing. You'll
So you keep this folded, and then this one is straight, and then you lie on the side like this.
Oh, you're doing this one, aren't you?
This one.
This one. And you want this straight.
And on the
This
side,
bent,
like
yeah.
this bent, and then this straight.
This one straight.
Yeah. No,
Do you want
this
both
bent, and but this one less, to a
Less
lesser
bent.
extent,
Oh,
yeah.
yeah.
Because I'm putting the probe like this, and then this is, I'm going in this way.
Okay.
So it's a bit lower than, well, it's on the
then you
outside,
don't
yeah.
have to-
Yeah.
pressing that
So I don't have to have you on the tummy, and then, or do this. Let me do a preliminary scan.
Why not?
Okay.
Maybe therapeutic this bit.
Putting a bit of jelly, please. Yep. Let's see what it looks like.
Yeah, that's off the screen now.
Yeah, I'm not naked.
Paint me like a pencil.
Spirit of Arthur, take over me.
Yes.
Oh, I see. That's why you go over. Fine, because you.
Yes, then you do this.
Sorry, I didn't know how to
Yeah.
explain it. I was just like, such odd questions. So
I thought, yeah, okay.
Okay. Just have to scan a little bit
But
more.
also, why would you not just stand this side and do it?
No, you stand this way, so your needle goes this way. So there's several ways you
Isn't it
can.
easier to do it this way? Like, I put ultrasound and then probe in that way?
Oh, like this way. No,
Yeah.
you always want to have the feel on the skin towards you, like the
You
top
want
this
more
way.
anatomy?
Right.
Fine.
Yeah, I'm trying to see whether it's normal.
Could you explain that to the camera, for anyone who's wondering? As well?
Okay. Yeah, I see something here. I see something here. Arthur, come along, sir. Come. So, normally I'm expecting to have. What depth is that?
It's not very deep.
It's not very deep.
This
Yeah, I
is
think.
the artery. It's-
Yeah, this is the artery here.
Yeah.
This is the vein around there, just
Then
slightly
it's
above.
superficial.
And so this is
Shiny.
where
So
it's shiny.
sometimes, depending on how you,
Yeah. Yeah, there it is.
yeah.
There it is.
So you can go.
So this is the artery, and then normally if I come with my needle comes in from this side. So this is just before they separate into the into the common tibia, the common peroneal, yeah. Yeah, there's tibia and the common peroneal before they divide. So this is actually just before they separate, and that's the best way to get them. And then I'll give in here, then my needle comes in through this way, and I can put in local here and there.
When you see,
Yeah.
when you inject this
That's
side,
not what people do.
sometimes you're not sure, and when you inject it, now it will become more defined. like
Defined,
as a
yeah.
round.
Usually I do a 2 mil, and then when it opens up, I now know where the limits are, then I follow. So I've taken them quite a little bit high, because if I go a bit lower, they tend to separate a little bit, but this is like the better position, because you have the artery there. That's the vein just above, compressible. Yeah, and then that is the package we're looking for. Then this is the tendon. This should be the tendon of the biceps femoris and other one of the semitendinosus. Semimembranosus. Or which one is on which side? It's
on this side?
on the medials, on the lateral.
Lateral side.
Yes. So this is semitenos, and then that is that of the biceps femoris, which is medial.
So
Yeah,
let's just scan
upwards. Yeah.
Oh, we've lost it.
No, there it is. It's still there.
There are two of them.
Yeah.
Yeah.
There.
Yeah. Here they are.
So it's actually a little bit medial.
Yeah.
I mean, lateral.
You've been saved. It's probably going to be the last one, right?
Okay. So this is the package we're looking for.
Are you going to Cameroon? How's your French?
One again.
It on the medial.
Oui, ça va.
Yeah. So this is it, right?
Yeah.
That's what we're looking for. That's the. Is that the package we're looking for?
Yeah,
This
that's-
one.
I think that's the one.
That's the one. Because I can see this guy down here. That's the artery. That's the vein, which is quite compressed. And then this is the package we're looking for.
It's a funny one because sometimes it looks white
Yeah.
and sometimes it looks like
Yeah. Yeah.
behind it. Anything that looks like
Yeah.
circular
Different, yeah.
above, superficial to the artery.
Can you
Cool.
somebody call the dinner place?
Cool.
The car
Yes.
just to let everything burn
Come,
out.
I tell you what to do.
Nice.
Sure.
So I tell you.
Nice.
Okay.
Didn't lose my spot.
The,
I don't like blocking adults. Like the kids. Everything's just large. Yes. Okay. Cool. I think we're so semi.
yeah, why not?
Jan, do you have enough?
I do. I just want him to give me access, and then I can send them to him. I just can't move. Come.
Another week's annual leave.
I don't have. Come. Okay, what's your name?
Okay.
Which one was it? Is Wix? Is your Wix account?
So personally, I'm not into learning too many blocks. 3 per segment is more than enough. ESP per vertebral. And in kids, we don't like blocks. I'm actually a pediatric anesthetist, so this is overkill for me. I'm like far away from my. No, I just do it because I need to teach it, but I don't like.
What do you do any blocks in children regularly?
Yes, yes, yes. I do paravertebrals all the time. Tap blocks. Yeah, thoracotomies for the classic. How do you call this one? Bilateral paravertebrals for. How do you call it?
Like a hernia one or
No. How do you call this? No. For these kids who have regurg.
like a fundoplication type.
Yes, fundoplication. So I do a lot of that bilateral for that. Then for like children hydatid cysts, esophageal atresia, and all everything that's chest surgery, I do paravertebral, especially in the neonates. Yeah.
Neonates?
Yeah.
Oh God.
Sorry about this.
I need to come work with you. Not doing that.
Because in the neonates I don't give fentanyl
Yes. Okay.
because I don't have the means to ventilate them after, so I want them to be. So I do a paravertebral block, and then just gas down, and then give them local on the cords, and then tube, and then at the end I just extubate, and then I run ketamine post them. Yeah, well, but the problem is since they usually come in late. That's what the problem is. Because managing them when they come in 3-4 days, TPN is rare.
But you can see how the image is clear enough. It's clear enough for surgeons to see very fine microsurgery. So it's easily good enough.
Yeah, so
So I'm calling them to come. The van to come at 8 o'clock. Are you guys coming on the same van?
Yeah.
Okay. I hope they've got enough space for all of us and stuff.
Sure, kids.
I mean, if you're calling them now, why don't you just make sure they've got enough space for all of us?
Yeah.
It's 6.
so this one is once or twice because I can do it in French as well.
Cameras and leave
You
the
can do
cable.
twice.
Yeah,
Okay.
Just leave everything.
We'll
where
try
it is.
that then.
Just going to pack the cameras.
Yeah, because if we've got an hour and 20, we can do 3 blocks, right?
So the should
Jonathan, we'll do this twice, once in English, once in French.
Yeah, cameras. Yeah.
Yeah, that's fine.
Cool.
Rapid, mate, rapid.
Yeah.
6 faculty, us 3, and then there is
3 brims,
and then 3 rims,
so that's 12.
12, and then how many suitcases?
Why are you bringing suitcases?
4 suitcases.
Why are you bringing suitcases?
I don't know. Do you want to go back? Do you want to bring your
No,
RIMS
just,
stuff
just,
on
just,
the
put
van?
just put everything in my room because you're all coming back here
Are you?
tomorrow.
Are you?
Yeah.
You're not taking your RIMS stuff in the van.
No, we're going to leave it in Simon's room, or we're going to be bringing the rucksack.
Okay, fine.
Just store everything in there. Perfect. You just can clear it out tomorrow. Because tomorrow I've got nothing to do
Is a very
apart from make sure the jeans logged onto the on a laptop, and then I can just sit at the back.
Well, if we can package these all to
Oh, Ryan, just this
we
one
can
more.
package these videos
Yeah. That'd be good. Yeah.
So I gave you one number.
Yeah, found it.
Can we good for it?
That'll be quite a tight deadline. But yeah.
Because I can't.
No, we should be fine.
Up, that's
say,
wrong.
Okay.
Can we move the van to 8 o'clock?
Yeah, there it is. You see it right?
And the van
There it
accommodate
is.
12 people.
At package.
So clear. And
Yeah.
just say who you are, please.
So in the bottom you can see the artery.
Hello.
Usually it's deep. This is one of the blocks, so you need to really go deep sometimes. 6 to 8 centimeters.
Yes, we're ready. No,
Yeah.
I think we're ready.
We're ready. We're ready.
So we've got 3 more procedures to film.
Yeah, we'll need Ryan. Do you want to get your tummy ready
Am I tummying as well? Yeah.
for the?
Let me just get
No,
this going.
Tommy's thingy.
Let me just get this going.
Who's it going to be?
Yeah, it's Tommy was me for the.
We'll rotate round. Everyone needs to contribute. Come on.
Because that's in the blocks and we on you.
Yes.
All the professors card if I can.
Everyone contributes.
Everyone contributes.
Mm.
To be fair, he brought all the cameras, so that's his contribution.
How many luggage did you bring? My God, 4?
We got stopped. I got stopped everywhere.
So this one is supposed to be here, right?
We'll need to adjust all that.
Okay.
No, so many leads, so many cables. Then they feel like I had a drone.
John, you ready for me to start
Order,
adjusting
the
cameras?
first bag they open is
Yeah,
the one with the
yeah.
simulator.
Alright, so the block's going to be here. Can you see my finger?
Do you want to do your probe?
Here. Yeah, so the probe will be here.
Yeah, that's good. That's angle.
Yeah, lovely. So I presume we need to move this.
Gene, you need to go.
After this, I'm doing tab, right?
I'm doing this twice. The reference. Yeah, for a sec.
Slightly higher up with the device. That's it. That's perfect. That's good. Good. So can you get your other camera?
PTZ?
That one's fine. PTZ is fine. We just need to pick up the mobile camera.
I do think sometimes it's useful, John, just to see the actual clinician relative to the body and the
Yes.
instruments, rather than everything focusing in on here.
Yeah.
Actually, when you're a
Mhm.
trainee,
Oh,
You want to see, yeah.
you're standing
Where to
here,
stand.
how you hold the instruments in relation to the equipment is
Yeah.
all an important part of the
Should we make,
process.
should we make this the
So you
position?
could zoom out and just have a more general position
Mm.
perspective rather than coming right into that.
This one.
You happy with this position?
That's fine.
Yes, this is fine.
Maybe just tilt it up slightly.
Okay.
Do you want us to zoom out on it? Is it zoomed
That's
in?
fine. No, that's fine. Where it is, that's fine.
And then I guess I've got the.
Gene's fine. The camera is good where SOAM is. That's a very good kind of angle.
This is your
Overlays are fine.
No, students looking at me.
Sound
Looking at this one.
fine. Say something.
Hello.
Can you talk to the mic?
Hi, hello. Hi, hello.
This
Yeah,
one
that's fine.
too.
Is that fine? Cool.
Alright, we're streaming and we're about to record. So 3, 2, 1, action and action.
Hi, my name is Raymond Dikonta and I'm an anesthesiologist from Cameroon, and I'll be showing a demonstration on how to do a popliteal block. So today we'll be doing a popliteal block on the right lower limb, and we'll have our patient lying on the left side of their body with the lower limb, the left side, which is the left limb which we're not blocking today, a little bit more folded than the right side we'll be working on. Now this block is a very interesting block for surgery involving the tibia, the fibula, and the ankle, but sometimes could be used for procedures involving the whole of the lower limb when associated with femoral blocks or with the adductor plane blocks. So to begin with, considering that we have already done the initial cleaning as required by standard, we get our probe and we make sure that we're using a linear probe, and the depth should be regulated a little bit deep depending on how big our patient is. Usually we should have a good view between 7 and 12 centimeters depending on how our patient is. So usually we scan at about 5 to 10 centimeters from the crease in the popliteal area, the popliteal crease. And generally at that point, when we scan, we should have at the bottom of our image, we just have to put some more gel. Okay. Here. Good. Quite generous with the gel. So when we scan at the bottom of our image, we should see the image on our ultrasound image. We see at the bottom the image of a popliteal artery, which is compressed at the bottom, usually at about 8 to 10 centimeters. And just above, we should have this image, which is the classic image of a nerve, about 3 to 5 centimeters beneath our probe. Now, at this point, we still have the popliteal nerve before it divides to give the two portions, which are the peroneal nerve and the common tibial nerve. But at this point, they're still fused, and it's the best point at which to get them. To inject our local, which we assume is already prepared, we inject given this position, and we stay in line with the probe. And generally, we should find the needle coming in from the left side of the image. I always prefer to, when I get in contact with the nerve, to give an initial 2 milliliters of local anesthetic to actually locate where the nerve is, with that initial spread, which makes the nerve more visible. And at that point, I'll give the rest of the volume, which usually it's about 30 to 40 mils. It's quite a good volume block, above and below the nerve, making sure to attain both nerves which are going down to the limb, and which will help with the surgical procedure which we are carrying out. Thank you.
All right, John, French.
French. Okay.
Right, guys, straight back in. French.
Okay.
Start.
Why French has to be
Because, yeah.
Is my
his voice.
His voice is fine.
Fine.
Finally go to the francophone countries.
Okay.
And
We used to get the Portuguese
Okay.
and Spanish reports.
there? Oh,
that's it, yeah.
You ready? You ready?
ready?
Okay. One. Faut que je le français. Ready?
Okay, one sec. 3, 2, 1. Action in French.
Bonjour, je m'appelle Raymond Dicontard et je suis médecin anesthésiste et je viens du Cameroun. Aujourd'hui, nous allons faire une démonstration sur le bloc sciatique poplité. Ceci est un bloc très intéressant pour les chirurgies du membre inférieur, surtout des chirurgies concernant le tibia, le péroné ou au niveau de la cheville. Il peut être associé à des blocs du nerf fémoral pour la chirurgie de tout le membre inférieur chez les patients polytraumatisés. Alors, il s'agit d'un bloc où il faudra un appareil d'écho linéaire réglé à une profondeur de 8 à 12 cm en fonction de la taille de la cuisse de notre patient. Alors, initialement, nous allons, après avoir nettoyé de manière classique, nous allons mettre du gel échogène et nous allons scanner. Initialement, l'image que nous recherchons est à la base de notre appareil d'échographie. Nous devons voir l'image de l'artère qui est comprimée autour de 8 à 10 cm, toujours en fonction de la taille de la cuisse de notre patient. Et au-dessus, au niveau de 5 cm en profondeur, nous allons voir cette image en nid d'abeille qui est caractéristique du nerf poplité. Cette image, en fait, est obtenue à 5-10 cm de notre creux poplité en allant vers la cuisse. Et à ce moment, nous n'avons pas encore une bonne séparation de l'artère péronée et tibiale. Donc, à ce moment, ils sont encore fusionnés, ce qui nous donne un très bon bloc si nous injectons notre anesthésique locale. Alors, à ce niveau, nous injectons en suivant le même axe que notre appareil d'échographie, en s'assurant d'abord d'injecter 2 ml d'anesthésique locale sur le maximum total de 30 à 35 ml. Les 2 premiers millilitres permettront de bien visualiser notre nerf. Après avoir injecté les 2 premiers millilitres, nous allons voir notre aiguille effectivement entrant du côté droit en fonction de notre position. Et ces 2 millilitres permettront de mieux voir le nerf Après, ensuite, nous allons continuer d'injecter une moitié de ce qui nous reste au-dessus et en dessous de notre nerf pour atteindre justement les deux chefs qui sont péroné et tibial. Merci.
No idea what you said, but that sounds
Yeah, just French. It's just. Yeah, Thomas. Okay.
Merci. Ah, can someone give me an
Okay. Ça va, non? Tu as compris, non? It's okay.
Went well?
Yeah, it went well. Leo. Leo.
Leo.
Leo.
You're doing the
No, I'm giving the.
Who's doing it next?
I'm the victim.
You're the victim.
to science.
Who's performing the demonstration? Who?
What tap?
Yeah,
Okay, so.
We're doing again in English and French.
it's better to have your head this way.
Can we do English and French?
I'll try. Yeah, I can do it in French.
You know the three layers.
You just want to
It's
grab
not
Yeah.
true. I changed it to mouthful.
External, internal, and transverse
We
abdomen.
can then oblique
Sorry,
extend.
did you mind describing those two things for me so you can lie down?
Comment on appelle transversus abdominis?
Le droit de l'abdomen.
Comment?
Non, non, transverse de l'abdomen.
Le transverse de l'abdomen. Ce n'est pas.
Non, c'est pas ça. Crochet.
Okay. Can we do the mental student camera?
Is that French? Oh shit.
Comment on dit transverse? Check Lionel, comment est-ce qu'on dit transversus abdominis module en français? Abdominal. Okay, yes.
Where do you want to be for this? Show me where you're going to be, and then we'll move the cameras around you. Do you want to approach from this side, this side?
It's better that side.
Okay, we'll turn it around then. Okay.
Mais toi, tu n'as
go around.
Are you doing English and French as well?
Yeah.
You take my hands away because you.
Yeah.
Yeah. That's what.
Yeah, I don't want to.
So
Bring me the echography this way. Perhaps you hold it.
where are you going to hold it, Jim?
You can hold it this way.
G is going to be the other side, so we want the PTZ.
You make a wonderful ultrasound.
Where's the needle?
Job. This.
Is it possible for this to zoom in on that rather than for us not to be the PTZ?
I can hold it if you want me to.
And then for us to back this to be the general one?
Also, I'm learning.
Jack, can you zoom this camera for me into the iPad?
Okay, tell me when to stop.
I think there's no hole. Yeah, you have to open.
Tell you how much.
Have you got the controller?
Move back for a second. You have the
Okay.
control.
You can choose maximum
Bring this this
size.
side and you come on the other side.
Sorry.
You want maximum.
Yeah.
Air do you need? You need
Maximum.
maximum air or.
No. Also for micrography. Well, maybe I should try first of all to locate her.
You can use your own phone.
Sorry.
Normally to do
Just on Android
tab
and
lock.
YouTube 360.
You can raise it to the side.
Oh, yes. So you
Sometimes.
Oh, just.
To show you, sometimes you do tab lock.
It's not big like.
That's it. Perfect.
Oh, yeah.
I'll throw
It's
forever
okay.
the VRiMS model. Everyone who looks well onto VRiMS will be like, who is that? G, you're quite zoomed in, so any little movements.
What's the image? Can we make it, can we optimize the image a bit?
Like
So
that?
you
Yeah.
go up slightly, or down, or her hold it
No,
down.
reduce again.
Hold it down.
Good.
Down or
Down a
up?
bit more. Down, down, down.
It's always good so.
That's it. Perfect. That's right there.
Voila, yes, you almost there.
your 360?
Like a tilt.
So
Good.
you start in the middle,
Yeah.
right?
Go laterally.
Go laterally to the till all those guys above meet the guy below.
Mhm.
And then, yeah, now you're getting there.
Yeah.
Yep. Now continue. Go.
Yeah.
Go. Go.
It's best mid axillary.
Go. Are you seeing? Look.
Mid axillary. Yeah. Go.
This is where you're supposed to
Yeah.
go to. So when these guys make this guy, you continue.
Yeah, that is our first external oblique, internal oblique, and rest tooth. And this is the plane we're looking for.
Exactly. So usually I like scanning from here.
show me your camera,
from the
please.
middle.
Mhm.
And then I go to the side when I start seeing these guys coming together.
Then we inject medially.
Yeah, but don't inject, please.
You got your needle? Yeah. Okay, good. Like that, yeah.
If you're getting close,
Okay, you currently got
if you're going to be close,
Joel's arm.
I'm looking for a way to stabilize my hand. And it's best.
Yeah,
Okay.
like that, yeah.
So you start.
So scan with your left hand. Are you right-handed?
Alright.
Scan with your left hand. Your right
And
hand
you
is
start
ready.
going down.
But this one, the hand will not be steady.
Alright, you ready, Sam, to show me?
Yeah, one sec.
can put
It's just a bit
your-
hot,
this
so I'm just
one
putting my
on
hand
the
in a place that doesn't burn me.
Okay, that's perfect. That's really good news. You've got really good.
My problem is stabilizing my hand.
Lovely.
Arrête ça comme le beat comme ça.
Really good.
okay, I think we're
Should I pull?
No,
Okay,
arrête ça
so
comme ça.
I'm ready as
Yes,
far
okay.
as I need to be. Are you
One
guys
sec.
ready?
No,
Yeah.
oh, not
Okay.
yet.
So
Okay.
record sand,
Okay.
streaming.
Somebody should give me gloves.
Just let me know.
That's good. You start seeing them now.
Okay. Give me a pair of gloves, please.
A pair of gloves.
Yeah.
Yeah.
I'm just going to put this on your legs. Don't move your legs.
Voilà, now you started seeing them.
Yeah.
Continue.
We can go at 8 o'clock, but he wants to know how many suitcases he needs.
No suitcases, just
So
Yeah, they're too long.
I've got a big rucksack.
We've got a room here to store
one
it.
bag and a big rucksack.
Thank you.
It's just four of us bobbing there.
Can you take, gentlemen, can he take all
Oh,
of
yeah,
us
gloves,
at one go? Or can he take all of us at one go? Or should
We
we
think we can do 12.
This is where you should be. This is where you should be.
Mhm.
The image you want to see.
Exactly.
Yeah. Because normally the typical part, you even have the person lying lateral like this.
Yeah.
But you can even do it like this. It's fine.
Oh, you'll get Friday? Yeah. When are you me and we going as well?
Oh, wow.
We're splitting because I'm going to Nairobi.
Okay,
Is
so
that the right one I'm pointing to?
Yes, that's the right one you're pointing.
Chill out. But we're going to the pond and lakes tomorrow and seeing the islands.
okay, yes, that's perfect in the afternoon.
After 4 p.m. Yeah. Us three and Karen and maybe Jean and Jan. Maybe Jean. I don't know. Yeah. Okay. Fine. Us three and Karen.
Change your point back belly.
Okay.
What's
Just
It's
what we
best
did
mid
on Johannesburg.
axillary.
Ah, no,
Mid,
yeah.
mid axillary between the subcostal margin and the superior iliac crest.
Yeah.
Is that not why?
Yeah.
Oh, very good.
Yeah, a little bit
I like to see the product.
anterior mid axillary. But it's okay, still okay there.
Consider, I'll have a job if I don't do well in anesthesia.
This is anaesthesia, isn't it? Just doing what surgeons want.
Dun, dun. She said this is anesthesia, right? Just doing what the surgeon
Direct
wants.
stabbing, enemy target.
I thought these were very just
You be very careful now. You're
Superb.
you're like
It is.
minority here.
Yeah, we are.
I thought you meant standing around holding things.
Yeah, I did mean that as well, but that was like.
It is not coming out clearly.
My
Yeah, you're
anaesthetist
going
is
to-
absolutely brilliant. Fantastic.
Yeah.
Really, really good time.
Most of us, most anaesthetists are probably the wrong
Expect
thing.
most of the cases, I mean, bear in mind most of my operations are 10 hours.
Yeah.
Expect most of the
Yeah,
time
you have to like them.
taking the piss out of me.
I'm still on the
Did you not just
rectus.
leave us trainee to after a while?
Yeah, probably.
East Winds is a bit of a funny old place because we don't
I'm surprising myself with this hand.
Let me see.
Okay.
I'm seeing better with this
place,
hand.
we don't have a lot of those things there.
Right.
So you just have a slightly more.
That's what you want to see.
Okay.
Yeah.
Fine.
Right.
Yeah,
That's what you want to see.
exactly.
Am I blocking the view, John? Can you just check?
No, you're
Yeah.
good.
Okay, now it's beautiful.
Yeah,
Okay,
exactly.
cool.
That's it. Perfect.
Okay.
In fact, it's showing.
Yeah, there's
cool.
Ryan, can you see if there's a switch for that light? Because we're not getting good lighting.
You're going to be too.
Oh yeah, that was good. Whatever you just did.
Voilà.
Yeah, you keep that, and there's another one.
Yeah.
Okay.
Voila.
Okay, we can start.
So we're going to be restricted a little bit by the light in this room as to how much more we can do.
Yeah.
It's starting to get quite dark.
Yeah, I think it will be good after this one.
Is this the last one?
So the curtains out. So that we can
Is this the last one? One more. Fine.
To
All right.
direct it whilst the belly is there.
Yeah, fine. So we've got John, 2 more to go.
On the belly.
This and another one.
We can do this, we can do this.
Yeah.
Okay, we can start.
Can we start?
Yeah.
Perfect.
Okay.
let as much natural
Good
light
luck.
in as possible.
Okay. Remember, you're talking
To the medical student.
to the,
Okay,
Yeah.
to this.
to this, yeah.
I'm facing this.
Yeah,
Yeah.
that's your student.
Okay, good.
That is the medical student.
But it's not. Or should I come? Should I come against front?
No,
Okay.
you're fine. It's
Good.
getting whole room.
Okay, okay,
Just
okay.
talk to that direction.
Okay, cool.
Okay, I'm going to start in 3, 2, 1 and go, yeah?
Hi.
Okay,
Okay.
Alright, wait. 3, 2, 1, go.
Hi. Hi. My name is Joel Toshi. I'm an anesthesiologist from Cameroon. Today we're going to be talking or demonstrating how to do the TAP block. TAP, which stands for transversus abdominis plane block. So this is a regional anesthetic technique used for low abdominal surgery or for all surgery below the umbilicus. What does this block going to block? It's going to actually block sensory dermatome from T7 to L1. So by doing this, we can anesthetize the dermatome or sensory innervation to the skin, and this can be indicated for surgeries like cesarean section, hysterectomy, myomectomy, as well as inguinal hernia repair. So, what are our landmarks? When we start this block, what are the instruments we're going to first of all need? We're going to need our ultrasound machine, our ultrasound probe transducer with a frequency of about 5 to 15 megahertz, as well as our needle, which is going to be a 5 to 10 centimeter Choi needle, round neck. Equally, we're going to need our local anesthetics drug, as well as all our sterile or antiseptic solutions. So, when we start this procedure, ideally, it's good to locate your ultrasound transducer at the midline of the abdomen. Best between you locate the subcostal margin as well as the superior iliac spine, and you start just midline, indicating always your transducer to the pointer towards the left region of your echography. So you start midline. Is going to show you your rectus sheath muscle, which is here. It is being shown as the hyperechoic pack, and you move laterally from medial to laterally. As you're going to move laterally, you're going to scan the abdomen, and as you move from the rectus abdominis muscle, which you're seeing, you're going to start seeing laterally the external oblique muscles, which is going to appear, then the internal oblique muscle, and lastly, you're going to see the transversus abdominis muscle, all appearing as 3 plane. This is it. So you want to administer your local anesthetics in the transversus abdominis plane, which is found between the internal oblique muscle as well as the transversus abdominis muscle. Sorry. So when this is located as the hyperechoic plane, you're going to take your needle, which you're going to place medial and almost parallel to your transducer, ultrasound transducer. The more lateral or the more medial and the more parallel your needle is, the better the quality or the resolution of your image. So you're going to move slightly. As you advance with your needle, you're going to first of all feel the first pop sound, which is going to be your external muscle pop sound. Then the second pop sound is going to be your transversus abdominis pop sound. That's where you stop. you administer 2 cc's or milliliters of your local anesthetic. It's going to distend your transversus abdominis plane. Is going to be seen as a hypoechoic injection or distension. And when you do that, you can now administer the rest of your local anesthetic. It's a volume-dependent block, so it's always best to administer between 30 to 40 mils of your local anesthetics. For the total block, you're going to do, therefore, 15 to 20 on each side, 15 on the right side, and you will complete with 15 to 20 on the other side. Always remember to add adjuvants to your local anesthetics like morphine derivatives, clonidine, and dexamethasone. Thank you. I think we should repeat it. We should repeat it. I'm not convincing. We should repeat.
From my point of view, technically, you were perfect, but Jag, can you just look at this a sec? Where we had the overlays, it's in the wrong place because you can view the technique there. You want the ultrasound there.
Je vais me répéter un peu. Je vais parler une fois.
Where the needle's going.
Well, I mean, they can always re-watch it.
Let me do it again and do it faster, please. I want to do it faster.
Can I also move the, John, I'm also going to move the camera there so I'm not getting in the way so much. Is that right? That way I can look that way. And that way I can see the needle and everything much better.
You were fine. The only point you weren't fine was when you stood really close in and your head got caught by that camera.
Okay.
Your angle was
His
good.
head got good.
Yeah?
I'll do for you.
I think it's better this way.
Better this way?
But just mind your head
No
on
need
that
to
one.
rush.
Okay.
That's the only thing.
En français, et on parle peut-être plus rapidement.
First, so you're happy and then we do it in English?
Je vais essayer. Je pense que ça va sortir.
Yeah, let's do it French first.
Well, English is my first language, but today I speak more French than English.
Oh. Where are you based?
Douala.
Where?
Douala, Cameroon.
Cameroon, nice.
Yeah.
And then the thing is, we're not indicating your landmarks on there.
That's why I want to repeat it.
Yeah, you were not indicating you were
Oh, very fast.
because
I want to take.
you actually use the
Can you give me a second chance to make it in English?
Yeah, fine.
Yeah.
Actually, like Arthur, when he used the needle to point, it's
where-
actually quite
where
good.
it's pointing.
Because
Okay.
finger, sometimes, it's hard to know what they are.
But I have the impression you were only looking at what I was. You were not pointing at the camera.
It's a wide angle lens.
Okay.
So if you point, they can see.
Okay, I see. Okay, I see now better. Okay, I understand.
And,
Okay.
and it was also.
Okay. No, let me do it again. I'm a perfectionist, please. Look at your big head.
Change the size.
But I should congratulate your belly. Est-ce qu'il est vraiment patient?
Quoi?
Quelqu'un qui a bu beaucoup de bière hier soir.
You're right. These are spot.
Oh, I wouldn't know how to.
No, she's someone else. No, not me.
Don't listen to them.
Big shoes to fit.
He can't move. He cannot cry. He knows that he's on a
And it is long, eh? I will just get into the peritoneum. Boom! Peritonitis.
Can we pass?
I will just.
Please,
I'll give him peritonitis at once.
can we cancel? Can we?
Okay.
La paix, s'il vous plaît. La paix,
Give me
bien.
1 second, sorry, 1 more second. Right. Okay, you're ready to go. I'm going to move the right just above you a little bit.
Yeah.
Okay, so I'm showing the face. Okay.
Nice.
That's very dark, that image there, because there's not much light.
Yeah. It's about, it's nearly
We're
sunset.
running out of light, guys.
Okay. Alright, let's do it.
Ready?
You ready?
Yeah.
3, 2, 1. one, go.
Hi, my name is Joel Toshi, anesthesiologist from Cameroon. Today we shall be demonstrating the TAP block anesthesia procedure. TAP, which stands for transversus abdominis plane block. So this is a regional anesthetics block used for low abdominal surgery below the umbilicus. For example, cesarean section, mammectomy, hysterectomy, just to name a few. So this technique is to carry out this technique, the patient is lying supine, as you can see, with the hands adducted. As you can see the patient doing so. We're normally going to administer all our antiseptic on the abdomen to make sure the abdomen is sterile. Then we're going to use sterile jelly or sterile ultrasound gel to apply to the abdomen. Then secondly, we shall be applying our ultrasound transducer to the abdomen at a frequency of about 5 to 15 millimeter hertz. So we start first of all medially, best between at the space between the subcostal margin and the superior iliac crest. We start medially and we'll move laterally. As we start medially, what we first identify is going to be the rectus sheath muscle, which is going to be seen as a hypoechoic pack of muscle. This is our rectus sheath muscle being seen on the screen. So we're going to move laterally. As we move laterally, the muscles we're going to scan as we move laterally is going to be the external oblique muscle, the internal oblique muscle, and lastly, the transversus abdominis muscles. Good. This is the plane. So here is our external oblique muscle, internal oblique muscle, and our transversus abdomen muscle. Muscle. What we're trying to do is we want to locate this plane, this hyperechoic plane, by administering our local anesthetic. So when we locate the transversus abdominis plane, which is found between the internal oblique muscle and the transversus abdominis muscles, we're going to administer our local anesthetic by injecting the skin medial to the probe. So as we inject and we move deeper, we're going to try to maintain as much as possible parallel or horizontal to the ultrasound transducer to get the best resolution of our ultrasound image. As we locate the transversus abdominis plane muscle with our needle as we move, we're going to inject about 2 mL of our local anesthetics that can be levobupivacaine, ropivacaine, as well as lidocaine, which can be supplemented with clonidine, as well as morphine derivatives to make the block to stay longer, as well as to be more potent in terms of quality of analgesia. So we administer 2 mL of our local anesthetics, first of all, to distend the plane and to make sure we're inside. As we confirm the position of our needle with the 2 mL of our hypoechoic local anesthetic distending, we can administer the rest of our local anesthetics to complete our block, and which is going to be 15 to 20 mL of our local anesthetics combined on one side. And we can do the same thing on the other side to make sure we have a complete bilateral TAP block. Thank you.
In French or move on?
Okay.
French, please, very quickly though. Right, we're literally going to go straight again. Ready to go?
Yeah, I can do it very fast.
Right. Gene, that's great. Yeah, so same again, please.
Yeah.
All right, 3, 2, 1, in French.
Okay. Bonsoir. Aujourd'hui, nous allons démontrer la technique du TAP block. Le TAP block qui est une technique régionale d'anesthésique ou bien encore un bloc nerveux périphérique anesthésique. Le TAP qui veut dire le transversus abdominis plane block, c'est pris de un mot anglo-saxon. Au fait, qu'est-ce que cette technique consiste à faire? C'est de localiser le muscle transversus abdominal et d'injecter notre produit anesthésique local dans la courbe ou bien dans le palier où ce muscle est, entre ce muscle et le muscle interne oblique. Et ce bloc nerveux périphérique est indiqué pour toute chirurgie sous-ombilicale de l'abdomen, c'est-à-dire les césariennes par exemple, toute césarienne, toute chirurgie par laquelle on va faire une incision phalanstyle, ça va être les césariennes, les hystectomies abdominales, également les myomectomies, également les héniorrhaphies inguinales, et on peut également citer également les varicocelectomies. Ok. Pour commencer cette procédure d'anesthésie, on a besoin de notre appareil d'échographie, on a besoin de notre sonde d'échographie, on a besoin des antiseptiques, on a besoin de notre produit anesthésique local, et enfin, on va positionner le patient pour commencer en décubitus dorsal avec les deux bras sous-élevés, c'est-à-dire bien étendus en extension complète, à presque 90 degrés. On va commencer par mettre la sonde médiane, presque au niveau ombilical, en ciblant la région entre la margine ou bien le bord sous-costal et la crête des épines iliaques. On va aller médiane jusqu'à latérale. Et quand on commence de façon médiale, on va voir le muscle rectus qui apparaît sur notre machine d'échographie comme des plaques hypoéchoïques, autant pour moi, qui sont là. Alors, on va quitter de médiane à latérale. En quittant de médiane à latérale, on va voir trois niveaux de muscles. Ça sera d'abord le muscle externe oblique, 2, le muscle interne oblique, et en dernier, le muscle transversus abdominal. Et qu'est-ce qu'on va cibler? On va cibler donc, j'essaie d'abord de repérer ces 3 muscles pour vous. Alors, voilà le muscle interne oblique, le muscle externe oblique, le muscle interne oblique et le muscle transverse abdominal. On va donc essayer de repérer cette ligne qu'on peut également appeler la ligne transverse abdominale. Et cette ligne va donc entre le muscle interne oblique et le muscle transverse oblique. Quand on est là, on va essayer donc d'injecter notre anesthésique local en allant de façon médiale à notre sonde. On va d'abord injecter en aspirant toujours pour être sûr que nous ne sommes pas en zone vasculaire. On va d'abord injecter 2 cc qui va permettre d'étendre ou bien de dilater cette margine ou bien cette ligne entre le muscle interne oblique et le muscle transverse oblique. Ça va donc dilater cette ligne et ça va apparaître comme une ligne un peu hypoéchoïque. Ensuite, on va administrer le reste du produit anesthésique local. Ça va être près de 15 à 20 cc ou bien millilitres de notre produit anesthésique qu'on va administrer complètement. Et on va également faire ça de l'autre côté pour avoir un bloc bilatéral. Bon, en tout, on va administrer près de 30 à 40 cc de notre produit anesthésique local. Merci. Ceci était dans notre procédé ou bien notre procédure de transversus abdominis spleen block, tab block. Merci.
I think we should stop here because I think it's just the lights now rapidly deteriorated.
Thank you.
How important was the other block?
Let's take.
We can do
We'd rather pack up all the equipment.
practice sheath block.
The lighting is just not good.
The lighting
So you need to join the Twitter, Instagram, LinkedIn. Share. What we say is 2 things in VRiMS. We speak
Asia,
about knowledge share,
tu veux les abdos? C'est bien ça, hein?
a boss.
Tu es un bon mannequin. Attends, je suis. Je pense que si j'avais eu un autre abdomen, j'allais ce truc.
Right, so we're going to pack up a little bit now. I think we should just
C'est bon.
cameras.
Parce que je pense que nous, on passe aussi.
On va même mettre la profondeur à 15 cm.
Ok, j'ai essayé en français, c'était pas mal.
Comme je sais, transverse.
We'll film tomorrow. Apparently the last one was too dark, so we have to repeat. Yeah, yeah. So you're up against tomorrow, is that okay?
Thank you. So, between the English and the French version, which one was better?
Doing both, you know, just to give a better light.
No idea what you said.
Tu as dit beaucoup de faux trucs.
Only the francophones understood me.
Non, tu as dit beaucoup de faux trucs.
That's why.
Mais le problème, c'est qu'il faut toujours, quand tu fais un bleu, il faut toujours spécifier où ton aiguille va passer dans l'image et où le bout de l'aiguille sera.
N'est-ce pas?
Donc tu fais entrer l'aiguille et tu dis que l'aiguille va passer comme ça et le bout de l'aiguille sera à ce niveau.
So that was is going to stop at the transversus abdominis plane, which is going to be the hyperechoic plane between the.
Donc qu'est-ce qui va s'arrêter? Tu n'as jamais parlé de l'aiguille. Ah, encore, moi, tu as parlé de
I said we're going to locate the plane. Location the plane is location with the needle now. You think it's location with your nose? Okay.
But anyway, c'est bon.
Merci.
This one, open one of those globe and put this thing.
There's no dustbin here.
I think about the